Now, I'm going to sort of outline, before I speak about the curriculum, some of the sort of the drivers for change for our new curriculum, and some of the sort of the bigger picture, the contextual issues that we within healthcare are grappling with, and you will be grappling with as medical students, as doctors, and they've been very much at the forefront of the design principles that have informed the ongoing changes to the medical program that we offer. So I think, giving this talk 4 years ago, I would have said very little about communicable diseases. I would have said very little about sort of infectious diseases, be they viral or bacterial, apart from perhaps concerns around antimicrobial resistance, which continue, particularly around the sort of the overuse of antibiotics and our inability to keep up with the constant sort of evolution of pathogens. And I think that is a sort of a clear and present danger, certainly to the provision of healthcare. It's been suggested that sort of, unless new antibiotics come on stream, operations such as hip replacements may be beyond the reach of most of us if we're unable to sort of control the infections that are often associated with such invasive surgery. COVID, of course, has been a major part of our life, and although the World Health Organization has called an end to the global emergency, I think many of our hospital wards continue to grapple with the ongoing sort of impact of COVID, and thankfully, as COVID has evolved, many of us have managed to avoid admission to hospital thanks to sort of advances in vaccines, in sort of antiviral agents. But nevertheless, it continues to have a sort of a significant impact on our lives. And I think, once again, it reminds us that communicable diseases are here to stay, and they are going to be a significant factor in the provision of healthcare going forward. I think what COVID has also done is it has highlighted significant inequities within our healthcare system. Those individuals who were disproportionately impacted by COVID were the elderly, were individuals with non-communicable diseases, and I'll speak a bit more around that. We've known for some time, but perhaps we've been sleepwalking towards this, that sort of globally we are aging. This is sort of great, and it is a product of advances, yes, within healthcare, but perhaps more importantly, advances more broadly within public healthcare. And by 2050, 30% of many countries around the world will be sort of over the age of 60. And whilst 60 is perhaps the sort of the new 50, and many of us are living sort of healthy lives well into our older adulthood, what we do know is with advancing years comes increased risk of non-communicable diseases. And those non-communicable diseases, those chronic conditions such as diabetes, such as ischemic heart disease, such as depression, such as arthritis, they have a significant impact on our healthcare system. They sort of drive our utilization of our healthcare system. So countries like New Zealand, like Canada, and we're not far behind in Australia, are sort of bracing ourselves for the increased need in our population for healthcare services. And I'll talk a bit more about the sort of the workforce challenges as we keep up with that sort of increasing need in a moment. Now, I mentioned associated with advancing years, but not sort of always directly proportional to advancing years, are the sort of the increasing sort of burden of chronic conditions. Now, in Australia, like in Canada, almost half of our population are living with 2 or more chronic conditions. A quarter of us are living with at least 1 chronic condition. As I've said, the more chronic conditions we have, the greater a utilization of healthcare services. And I think what we're noticing as well, particularly as we look at sort of how our healthcare systems can continue to sustainably provide for the needs of our populations, is that sort of the way perhaps we provided healthcare in the past, which is an over investment in specialist services, is perhaps no longer fit for purpose. That as we recognize that more of our population are living with 2 or more chronic conditions, the role of the generalist, be that a general practitioner, a general internal physician, a general pediatrician, is becoming much more important. Evidence would suggest that if you have a single condition, seeing a specialist is often associated with better outcomes. But if you have 2 or more conditions, a generalist is better placed to work with you to look at the trade-offs between various therapeutic options to ensure that you're optimally cared for. One of the first principles of being a doctor is do no harm. And sadly, the combination of many sort of medications and sort of interventions can have a deleterious effect on us, impact our quality of life and shorten our life. So I think what we're now seeing is that perhaps the pendulum needs to swing back in favor of general practitioners, general internal physicians, individuals who can work with us, walk with us as patients, and ensure that we receive the optimal treatment and better understand the trade-offs between the various therapeutic options available to us. And I think that sort of recognition that general practitioners are a significant part of the future of healthcare. In fact, the best performing healthcare systems around the world are the ones that have preferentially invested in general practice, is very much the heart of the discussions that we're having as a community here at the University of Queensland, and at the heart of some of the design principles that will feature in our new medical program as well. And I know from discussions with the president of the Royal College of Surgeons and Physicians of Canada that it is a live discussion in Canada as well, with 6 million Canadians currently not having access to a general practitioner. And that is sort of a clear and present threat to the provision of universal healthcare, not only here in Australia, but also in Canada, and something which we as a community have to be part of the solution for.